Could we have the next slide, please? So I'm sure some of you will be familiar with this medication chart and also the one that will follow. This is an older version, but I still use it because I like it. There's a newer one, which I'll show you shortly, and then there's an even newer one coming out soon. I can forward anyone a copy of this who would like it. If you've been to the Parkinson's clinic at Concord, you would be familiar with this because we use this in all of our sessions. When people come for the all-day assessment, because medications is a very important part of that, although it's not all of it, we start off the day by clarifying what medications everyone's on, the actual medication itself, the dose, the time it's taken, how it's taken, and what other things it's taken with. And we go through quite thoroughly and work all of that out so that we're all clear about it, because it means that it'll give us all the information if we are going to be considering changing any of the regimes, but also it's just nice to know, for example, if the physio is assessing somebody, they can quickly glance at it and see what time the medication was last taken. So they know if the person that they're doing a task with, where they are in their dose cycle. So that's really useful information for us. And then we get people to take this chart home, we put a date on it, and they can give it to anybody else, pass it on, and they've got a really good record of what they're on. So if we could just go to the next one, which is the newer chart, but as I said, the one that I don't like quite as much, so I kind of use both of them. The chart that will be out later this year will hopefully combine those two charts so that it'll be more comprehensive. Each chart is actually missing something, so that's why I have to use two. So it's just really handy to see what you're on, what else is available, what other doses are available in the medication that you take. And it's a good discussion piece for when you're with your neurologist actually discussing medications, and our neurologists use it just to clarify which actual dose is used, especially like if you can see with Stalevo. I'm not sure how well you can see it, but there's many doses, and we need to make sure that we document the correct dose because it will impact everything else we do. So they're our starting point for just talking about medications, seeing what people are on, seeing if there's any questions about it. And this slide, Duodopa, is just explaining one of the medication charts is totally missing Duodopa, and the other one just has it as a word. But so I find this useful to show people that this is actually a medication for Parkinson's. This is like Cinemed in a pump, and not everybody's seen this or is aware of this. And as I said, it's not clearly demonstrated on the medication chart. So it's one of the 3 advanced therapies that we talk about, or device-assisted therapies. There's apomorphine injection or infusion, there's Duodopa infusion, and there's deep brain stimulation. So the first 2 are medications and the other one is a device, but we call these 3 collectively device-assisted therapies, and they're for people that are no longer happy with how the oral medications are working. Okay, so there's 3 main categories of medication which can be seen on the previous medication charts. They're dopamine replacement therapy, which is what most people will be on, which is Cinemet, Matapar, Kinson, Stalevo, or there's a couple of other like Syndopa, a couple of other overseas brands as well, but it's basically levodopa. So that's just doing a straight replacement of levodopa into the brain. When your body's no longer producing it, this tablet just basically deposits some levodopa into your brain, as should be there. The second category is dopamine agonist. This is something like Cifrol or a Nupro patch, for example, which some of you might be on as well as the levodopa. Very occasionally people take this medication first, but more often than not, they take it following starting levodopa as an add-in. And then the third category is MAO-B inhibitors, and there's quite a few of these, but the ones that are commonly known are Azilect, and Sedago. So they're the two really common ones. And they work really well if people are already on one of the others or two of the other categories. They can be a good add-on to complement, and the three work very nicely together. And it also means that we can keep drugs in all three categories at a reasonable level so that we minimize side effects. If we couldn't combine all three categories, if we just push levodopa up to incredibly high doses, people would have too many side effects from that. So that's why we tend to use different drugs from different categories. And some of you will be on anticholinergics as well. So that's things like Artane. We don't use those as commonly anymore, but some of you might be familiar with those. Yeah. So when you're first starting medications, following diagnosis, who should start the medications? Well, occasionally we see that it's done by the GP, sometimes a neurologist, sometimes a Parkinson's specialist neurologist, and sometimes other. So, of course, our preference would be a Parkinson's specialist neurologist. So if that's happened with you, great. If it hasn't, then it should be reviewed by a Parkinson's specialist neurologist just to make sure that you were started on the correct dose. What they prescribe will depend on a lot of factors, and they will work out whether to start you on levodopa or a dopamine agonist, and they'll decide what dose, and that'll be individualized, which is why it's preferable to come from a Parkinson's specialist neurologist. It's often levodopa, and it's often starting 1 tablet 3 times a day. That's the minimum dose of levodopa to get a symptom relief. It might be weaned up to the 1 a day, but that would be the end dose. That would be a fairly standard way to start medications. Where are you going to have your ongoing appointments? That's up to you to decide. Would you continue to see the doctor that diagnosed you and started the medication? Would you like to see someone else? Are you going to go public? Are you going to go private? Are you going to do face-to-face? Are you going to do telehealth? They're all things that you do to suit yourself, but also in consultation with the specialist available. And I think it'll also depend on how involved you were in the process of the medication starting, how much information you would be given as to whether you probably choose to stay with that doctor as well. Sorry, I'm just getting over a cold, so I'm a bit coffee. With your ongoing management, so, you might have started the initial dose of levodopa, you've been on it for a year or so, you're obviously going to continue on it into the future. So who should be managing that going forward? Well, again, we'd say a Parkinson's specialist neurologist at a minimum of once a year, absolute minimum, preferably twice a year, to review the dose. Again, what to take? Well, if the starting dose, excuse me, if the starting dose was effective, presumably you would stay on that medication. If it wasn't doing so well, they might try something else. And they would be doing that in consultation with you. You would be telling them how effective it was, whether it suited your lifestyle, whether the amount of tablets you were taking was suitable, all of those sort of factors you would discuss together and work out a plan going forward of what would be the best medication for you. And make sure you understand the plan. Make sure that it's really made clear by them how often you need to see them, where you need to see them, how. For example, here someone in early stages of Parkinson's, we might say, we'll see you face-to-face once a year, and feel free to have a telehealth every 6 months if you just want to check in, but you don't want to traipse all the way in here because we have a lot of patients that travel. So we make the options really clear. We make advice on what we think would be the good timeframes, but then obviously you have to do what suits you as well. So balancing symptoms with side effects to get the best results. So this will happen, this balancing act will be effective if you have a good Parkinson's specialist neurologist who you report very well to. So if you're able to accurately report your symptoms and also your side effects from medications, then they can work out what to do. And if you're not sure which is which, you just tell them, and they will then tell you if it's a symptom of Parkinson's or a side effect of the medication, because sometimes it's confusing as to which is which. And that way they can work out the balance of how much medication is right for you, getting the best level of function possible without giving you a dose that's so high that you get those really worrying symptoms that can sometimes be worse than the initial symptom that we're trying to treat. So this is kind of a history that you'll be bringing into your appointments. If it's a new doctor, you should always let them know of any previous side effect to any medication you've tried in the past, because they might decide to put you on it again, and they don't need to do that. If you've already tried it and had a nasty effect, then they would try something else. So if you do switch doctors, make sure you do give them that history. Discuss your lifestyle with them when they're working out the medication regime, because they won't know what your needs are. You could be someone who still has school-aged children that you are bustling with. You may still be working. You might be doing a lot of exercise. You might be having very long days, up very early, going to bed very late, and might need a lot of medication. On the other hand, you could be in residential aged care. You could have carers around the clock. And so being on all the time is not as critical as the first scenario. So therefore, they may be able to give you a little bit less so that you get less side effects. So they just need to know what's your days like, what your demands are like, and then they can work out what sort of dose to have you on. So every person with Parkinson's requires a different medication regime. So thinking back to the charts and how many tablets there are, how many doses, how many combinations, are you going to be on one from 1, 2, or 3, or even 4 categories? What doses are they all going to be? You might be very familiar with the tablets because you'll talk to other people on similar tablets, but their regimes will just be slightly different to yours, and they'll be individualized to them to get the best function for what they need to do. So it's very important to give the doctor lots of information so that they can deliver that sort of care that'll be most suitable for your individual case. We talked a little bit before about symptoms and side effects, and it's very hard sometimes to know what's what, and even sometimes we get confused about it. So if you're not sure, just ask. It's really important, though, that if you are reporting something that you are if it's a telehealth or you ring me or you're needing some advice, it's really important for us to tease out if it's a symptom or a side effect, because the outcomes are almost the opposite. So if you have a symptom that's new or increasing, we would increase your medication to treat that symptom. But if what was happening was a side effect, we would do the reverse. We would decrease that dose so that we could try and reduce that side effect. So it's an opposite cause and effect. So if we get it wrong, we're going to make you twice as bad. So just be careful with symptoms and side effects. And as I said, if you're not sure, just ask the doctor and we can tease out which is which. It's sometimes very, very hard to tell the difference. So I suppose I'll give an example. So what most people relate to in a symptom would probably be maybe a shuffling gait. So you're walking slowly, your feet are sticking to the floor, and you might even slow down when you approach a doorway or something like that. That should be familiar to a lot of people. So that is a symptom of Parkinson's, and we can treat that by increasing the dose or even introducing another medication. An example of a side effect might be the involuntary dyskinesia. So that's when you get those involuntary movements that you may be aware of, or your partner might be even more aware of and point out to you, where parts of your body or your whole body is moving and you can't control it and you can't stop it. That's called dyskinesia. That's a side effect of medication. Sometimes people report that to us as shaking, and shaking could mean tremor, or shaking could mean dyskinesia, and the outcome would be the total opposite. So that's why I just say we clarify. If you had dyskinesia, we'd have to decrease the dose. Medications to take with caution. So luckily, most Parkinson's medications are safe to take with other medications. So if you were, example, under the care of a cardiologist and they had you on some cardiac medications, you would need to make sure they had the list of the Parkinson's medications, and you would also make sure that your both doctors had both lists of medications and they could talk to each other and make sure that they're not interfering with each other. And in most cases, they would not. But there's a few drugs that are not good with Parkinson's more than the Parkinson's medications. And they are things like antiemetics. So Maxilon and Stematol are the really, really common ones. These are drugs that people are prescribed all the time. They're for nausea and sometimes dizziness. They're first-line routine. So if you went to the doctor and you're nauseous, it would be totally normal to get a script for one of these. But unfortunately, they just make Parkinson's a lot worse. So there's another drug called Motilium that if people with Parkinson's have nausea or dizziness, they can have the Motilium. And so the GP would prescribe that instead. There's a couple of pain reliefs like pethidine and tramadol can upset with the Parkinson's. So for a comprehensive list, you can get that from Parkinson's New South Wales. I think it's just called medications to take with caution. I'm sure it's on their website. And you can just check with what you're taking. And some people just keep a little note when they go to the doctor with a few key medications that they can't take with Parkinson's, particularly Maxilon and Stematol. It's a good idea. Your pharmacist is often really good at picking this up as well. So if you go into your pharmacist with a script and they've got your whole history of what you take, they'll often flag to you that this medication's not going to be good for you, which is really good backup. When in hospital, obviously the goal would be to ensure that your medications are taken on time every time. And I'm sure a lot of you are familiar with this. As PD nurses, we talk about all this time, meds on time every time. We know how important it is. You know how important it is. Sometimes we have to teach the ward staff how important it is. You might not be on a ward with many other people with Parkinson's and the staff may not know. It's quite a specialised field, so we wouldn't expect every nurse to know this, but after you inform them, we would expect them to make every effort to get you your medications on time. If you know that you're going to hospital for an elective operation, you can take your list of medications and what time you take them at home with a little note that this is really important, that you take them at this time, because otherwise you might find that you get the right tablets when you arrive, but you get them on the hospital schedule, not on your schedule, because they didn't realise the importance. So sometimes you've got to point that out to them. You may be able to negotiate taking your own medications if they say they're too busy to give them outside of the ward times. You might be able to negotiate to give your own medications. You might need someone else to be an advocate on your behalf if this is not going well. We do have a lot of trouble with this. I'm skipping around a little bit, but just because I am from the clinic and you won't all know me and you won't all know our clinic, I just thought it was important to note that medical is a big part of our clinic, medical being medications, but it's not the only part. The allied health will supply information, strategies, equipment that will all help to assist with the medication management. Just taking a tablet and doing nothing will not be effective for some people. They might need to be doing some physio. They might need some walking aids to prevent falls. They might need some strategies with how to cue to take some bigger steps, for example. So those strategies work in very well with the medications. And patient and family. So we see patient and family in our clinics so that we can get more insight as to what's happening at home, so that we can better medicate patients when we know what's needed. We can provide information to families who may not have a lot of information, depending how long someone's had Parkinson's, which doctors you've been seeing, etc. So we do provide a lot of education to families, and a lot of that is around medications as well. So getting the medication regime by, you know, a Parkinson's specialist neurologist that you communicate well with, that you trust, that communicates well with your GP and other specialists, is really crucial. But don't stop there. Make sure that you've got good allied health support, and make sure that your friends and family are getting the education and support that they need as well.